everyone. Good morning, good afternoon, and good evening, wherever you are in the world, and welcome to the fourth meeting of the iStrategy Partners. My name is Nika Alexander. I'm part of the communications team here at WHO headquarters in Geneva, and I'll be your facilitator through the next 2 days of meetings. I hope to help it run more smoothly, especially when we just transition from one section to the other. As we start off the top, just a few items of housekeeping. First of all, there will be interpretation available in 4 languages. To look for the interpretation, look towards the bottom of your screen on your Zoom page, and you'll see where you can click on interpretation. To the bottom, should be to the bottom right-hand side of your screen. Secondly, because we wanted to hear from so many people and update you on the whole range of work that everyone's doing, time for each presentation is really short, and we ask that all presenters really keep to time. Our colleague Raki Verma will pop up actually when we've reached time to let people know that you're at the end of your slot, and that will allow more time for the next person and for discussion as well. For discussion, what we have set up is a software called Slido. You may have used that before in other meetings, and that allows you to ask questions. So it's not here in Zoom, it's over in Slido. You will have received an invitation to join Slido, and the links I think might be appearing on screen and in the comments for you now. That's where we'll ask you to drop in your questions, see if somebody else has asked a question you're interested in hearing an answer to, and you can like questions, which will lift them up higher in the queue and increase the chance that they will be asked. If you miss anything, all the presentations, the videos and information are available on the WHO Events app. There's information on how to get that app as well. If there's any technical failure, we'll have backup recordings of some of the presenters as well. So most presenters will know if they've had a chance to record a video ahead of time or not. The bulk of the presentations we hope will be in person, however. So just before we launch, just 2 quick words from 2 of our colleagues before we go into our first keynote. I would like to hand the floor right off the top to Renee van der Weert. She's the Director of Health Emergency Interventions, Acting Director in the Emergencies Program here at WHO. Renee, over to you for a few words. Can anyone see if Renee is there? Otherwise, we might go to you first, Laurence, and then switch back.
Can you hear me now?
Yes, we can. Go ahead.
Yes, sorry about that. I had difficulties with the audio. Thanks a lot, Nika. And I wanted to switch on my video as well. Thanks a lot. I'm really delighted to be here with you all for this very important partner meeting. As Nika mentioned, my name is Renee van der Weert. I'm the Acting Director of Health Emergency Interventions. And in that department, there are 3
I've lost audio. Can other people hear Renee? No.
We should be able to hear her in a few seconds from now.
Okay.
Okay, trying again. Sorry about this.
Can hear you now.
And I'm also then trying to do the video. Thanks. And sorry again, Nika and colleagues. Can you hear me now?
Yes, hear you and see you.
Wonderful, thanks a lot. And good afternoon, colleagues. I'm actually really delighted to be here with you all. As Nika mentioned, my name is Renee van der Weert. I'm the Acting Director for Health Emergency Interventions. And in that department sits the high impact epidemics, of which yellow fever is of course one. That department also hosts the Global Health Cluster and its partners, which are important partners as we roll out the iStrategy, but also the fragile conflict affected settings, which of course many of those settings are impacted by yellow fever. For us in the emergency department, it's really important to protect all people from infectious hazards and emergencies, and really to make sure that we implement at scale proven interventions for epidemic prone diseases. And that of course includes yellow fever. It also includes vulnerable settings because we want to make sure that there is equitable access to these proven interventions and that nobody is left behind. Of course, we do this in partnership, and I'm really delighted to see so many partners online. Of course, with NGO partners, those that are part of the cluster, those that are not part of the cluster, academic partners, UN partners, and of course, donors. And I'll be listening in throughout this afternoon and tomorrow, and really want participants to give honest feedback on what we in WHO can do more to really bring partners together to make the I strategy a reality. And that will be it. I wanted to be brief. I'm really eager to listen to the interventions from other colleagues. Thanks, Nika.
Thank you so much, Renee. Next, for the objectives of the meeting, a person that I'm sure you all know, Laurence Sibelius, who's the lead for the I strategy, will give a brief overview of the meeting objectives, and we'll hear from her soon after as well. Over to you, Laurence.
Thank you, Nika, and good afternoon, good morning to all. It is indeed very nice seeing you connected from so many places. These are very complex times, and these makes your presence today and what you reflects of your engagement all the more meaningful. So together over the last, the coming 2 days, we are going to review the I strategy achievements and challenges to date, including in the COVID-19 context, to discuss key lessons learned from recent prevention and control experiences to inform further I implementation, to prioritize next steps for the I strategy with strengthened partner engagement, as well as country and cross-regional collaboration. And we will foster a healthy yellow fever vaccine supply situation. So thank you all again for your presence today, and looking forward to a fruitful meeting. Over to you, Nika.
Thank you, Laurence. Next, we have our opening presentation by Dr. Ibrahima Sosé Fall, who's the Assistant Director General for Emergency Response at WHO here at headquarters as well. Unfortunately, he couldn't join the meeting today, but he recorded his introduction to you this morning. He was just recording it this morning, so it's fresh, and that's what we'll go to next, if we can have the video of Dr. Fall. Thank you.
Dear colleagues, dear partners, ladies and gentlemen, it's my pleasure to be with you again for the 4th I Strategy annual meeting. Together, we continue to protect and save millions of lives despite all challenges through solidarity and commitment. The success of I starts and ends with countries through strong country engagement and leadership, with support at regional and global level. We can realize the vision of the I strategy through ongoing control of the risk of yellow fever epidemics globally. The goal of the I strategy is to control yellow fever risk in a holistic manner, with the focus being on protecting population in high-risk countries, preventing international spread, and rapidly controlling outbreaks. The COVID pandemic is a dry illustration of the threat represented by diseases that spread internationally, and of the specific and difficult challenges associated with the control of human outbreaks, also the case for yellow fever. Despite the unprecedented challenges brought by the COVID pandemic, countries have found innovative ways to maintain the momentum of implementing yellow fever emergency outbreak response and preventive vaccination activities, thus demonstrating their ongoing commitment. The support of the I partnership has also been instrumental in this effort. I want to applaud Nigeria, Ghana, Uganda, Ethiopia, and South Sudan for mounting large-scale yellow fever preventive and reactive vaccination drives during this time. I know the Democratic Republic of Congo will also do so in the near future. The increased risk of yellow fever urban outbreaks with international spread is a major public health issue that we need to tackle as a multi-sectoral and multi-level community. Once again, we thank you for your engagement, expertise, and partnership.
Thank you, Sosé. Thank you, Dr. Fall. And now we're entering our first session of the day. And I will, each time we start a new session, I will quickly read off the objectives for that session just to ground you a little bit. So this first session is progress in implementing the I strategic vision. It's to provide an update on the achievements and challenges at the global level, to summarize progress to date in comparison to what the strategic vision was. After this, we will have a poll. This is slightly different from other sessions where we'll ask you to think of questions and drop them in Slido. In this case, in fact, we're going to have a poll immediately after the session. So first off, I'd like to hand over to Laurence Cyprelus, the I strategy lead.
Thank you very much, Nika. Sorry, I was on mute a bit. And I will indeed provide an overall update on the I strategy as Secretariat. Specifics will be discussed in subsequent interventions, and I really wanted to greatly appreciating the work from all. Yellow fever is a high, if we can move to the next slide. Thank you. Yellow fever is a high impact disease that is epidemic prone, vaccine preventable, and vector borne. It demands sustained risk mitigation efforts to reduce morbidity and mortality and to avoid urban outbreaks and international spread that would threaten global health security. Yellow fever urban outbreaks are dramatic events with a complex and very resource intensive response, as was experienced during the 2016 Angola and DRC crisis, as was feared in Brazil in the 2017 through 19 seasons, or as is an underlying concern in Nigeria. We aim to prevent these outbreaks and mitigate their impact by protecting at-risk populations, preventing international spread, and controlling outbreaks rapidly. Our role is critical given marked changes in land use, population movements, urbanization, with increased risk of sylvatic spillover into human communities, onto urban settings and internationally. The global reemergence of Aedes-borne diseases is a signal of vulnerability in yellow fever endemic countries where immunity gaps exist, and a potential local risk of epidemic amplification in case of importation in non-endemic countries. The increased yellow fever virus activity in Nigeria and in Central and Eastern Africa, where immunity levels need to scale up, are priorities. There is also growing concern in several West African countries protected by campaigns under the Yellow Fever Initiative, and where immunity gaps and suboptimal routine coverages could lead to reemergence if these gaps are not closed. COVID-19 also increased yellow fever risk via challenges to timely detect and respond to outbreaks, to mount preventive drives, and to provide routine services. COVID-19 shook the world, but yellow fever is not a new disease. The risks and needs have increased, but we have a strategy and we have a partnership that provides a dedicated mechanisms to coordinate the efforts to integrate the activities that will make a difference for yellow fever with existing or developing initiatives, and to ensure that the yellow fever topic remains high on the global health agenda and on these of countries and partners. Since 2017, and using the example of Africa, more than 136 million people have been protected with completion of campaigns in Angola, Sudan, and Ghana, and an additional 48 million people should soon be protected in Nigeria and DRC via campaigns. There also is stronger laboratory capacity and streamlined international samples transport, leading to faster confirmations. These figures do reflect the greater recognition of risks and the greater engagements as the community got organized, and we will hear from all. In addition to the perspectives brought by the 4I working groups, we have tools for streamlined, transparent, and evidence-based decisions. Beside the monitoring and evaluation framework to track progress and course correct if needed, we have standard procedures to decide on vaccine allocation with a multi-year perspective, allowing for contingency planning. And these mechanisms, combined with a risk prioritization tool developed by the risk group, is essential to optimize the yellow fever vaccine supply, which markedly increased and is a major enabler to rapid rollout and to meeting the demand for Africa as currently quantified over time and accounting for programmatic considerations. The next slide illustrates mostly the preventive campaigns and routine activities anticipated through 2022 in Africa. It is actually here to highlight the importance to formalize the demand perspectives after 2022 and to quantify the demand beyond campaigns and routine introduction, namely the immunity gaps in West Africa, those linked to COVID, the demand in the Americas, and any potential strategic adjustment linked to risk evolution. In 2020, COVID challenged us to continue to respond to countries' needs related to yellow fever outbreaks and all planned activities, to maintain prioritization of yellow fever and to prepare for post-COVID times. But there are impressive examples of how the partnership came together across levels and organizations to deliver on plans, as in Ghana, for example. We've made important progress to date. And looking ahead, there are 5 key areas that need to accelerate and will be further discussed during the meeting. First, increasing surveillance capacity to better understand risk and disease burden with the granularity needed for informed decision and to optimize resources. These efforts will also contribute to the characterization of risk beyond current endemic borders and especially in fringe areas. We also need to address risks more finely, using the risk tools existing or being developed to inform strategic priorities. We need to characterize immunity gaps, define policies to close these gaps, and ensure that the mechanism to materialize these efforts exists within the partnership. Very importantly, increased and sustained high level of routine coverages are critical to prevent reemergence on the long term. Also, there's a lot the global community can learn from Brazil regarding new clinical management approaches that will improve patients' outcome, but also potentially positively impact surveillance, as the hope offered by better treatment perspectives could incentivize patients to seek care and therefore be detected through surveillance. And finally, it is essential that we manage yellow fever urban risk and be ready to detect and respond to urban outbreaks. We need a plan, and this will be a key contribution from the I strategy to the cross-cutting global arbovirus strategy under development, and that would be complement to existing strategies such as I. I also note that IHR is taking a new dimension in the COVID context that might influence our ability to prevent yellow fever exportation and importation. Now, looking ahead at our ways of working, there are 3 key areas that will be further during the meeting, discussed during the meeting. First, the essential role of country ownership with implications for sustainability, integration, and synergies across the different facets of yellow fever. In Brazil last year, we were keen to foster cross-regional collaboration, including via twinning of countries across regions and work areas, and via mentoring. And finally, to all as partners, the I strategy is your strategy. It cannot be successful without your active engagement, without your advocacy, and without your active support in country when needed. And also to tailor I implementations to areas experiencing fragility, conflicts, and violence. And with that, I'd like to thank you very much for your engagement and partnership, and passing it back to Nika.
Thank you very much for that overview. So this is part of the meat of what we will be discussing going forward. So we're going to try something here. I said that normally we'll be taking questions on Slido, but this one time we're going to be doing a poll right here in Zoom. So you should see a poll popping up now with 2 multiple choice questions. Nobody will be graded, don't be intimidated. You can choose as many of these answers as you wish. There's 2 questions, as I said. You scroll up on your screen with your mouse to see the second question. So the first one is, which areas do you think we should make more progress with in the future? Which areas do you think we should make more progress with in the future? And there's the 1, 2, 3, 4, 5, 6, 7, 8 options. You can click on as many as you wish and then scroll to the next question. Which areas do you think you or your organization could contribute to the most? And then choose as many of those as you wish. So I'll just give you a minute to click on your answers here. And you just click submit at the bottom once you've made your choices. I don't think we have interpretation for this, I'm sorry. So please do your best. Ngum, let us know when we have the answers back. I don't see anything on my screen at the moment yet.
Yes, for now we have 88 out of 154 participants who have voted. 89.
Okay,
so
that's good. So we have half. If it's helpful, actually, I was going to say I could read the question, but since I submitted an answer, I don't see it on screen anymore. Perhaps the interpreters could read through if they're able to see the poll themselves.
Okay, I'm going to paste them on the chat.
Thank you. So what we'll do next is we'll discuss these, we'll discuss the answers. And so I'll be asking those of you who replied to some of the specific ones, for example, whichever one was most chosen, to tell us why you thought that was key, first around the first question and then around the second question. And we will do this, in fact, in Zoom. So we'll ask you to raise your hand. If you want to practice doing that now, you click on the participants button at the bottom. And when you click on that, you can see the option to raise your hands. I'll be quiet now in case the interpreters are working through the questions.
Yes, so I've pasted question 1 and question 2 on the chat for interpretation. And as of now, we have 106 responses received out of 159 participants. Over.
All right, can you tell us how many answers we got in the end, Ngum? Then
Yes.
I think we can close it.
We've got close to 70% of the responses. That's 111 responses.
That's great. Thank you, colleagues. Thank you for your rapid input. So let's see if we can post the results now of the poll. They should just pop up on your screen. There we go. So in the first section, the question which was, which areas do you think we should make more progress with in the future? 68% of you chose surveillance. Second to that is 58% on strengthening routine immunization, followed by laboratory and diagnostics, and then neck and neck for the other ones. And then before we go to question 2, maybe just discuss around that. So would anybody like to give their view on why surveillance was key and why they chose surveillance? If you can just put your hand up in Zoom, and we'll come to you. My colleagues are monitoring Zoom to see if we have any questions. We see one hand up. It's Professor Anthony Onimisi. Professor, go ahead and let us know why you made your selection. You can unmute yourself.
Thank you very much. Coming from experiences of polio in Nigeria, we know very well that if we can make surveillance, if we can work more on surveillance in the area of surveillance, that we can forecast, as it were, the likely places, the likelihood of having yellow fever outbreaks. It makes sense. So that means we are going ahead of the yellow fever virus instead of reacting to outbreaks. So if we have tools, for example, okay? That when we use the tool, it will have criteria that will measure or that will give us prediction or forecast the likelihood of having an outbreak in any part of Nigeria. I think it will help in a long way. Currently, the sensitivity of our surveillance tool are not able to predict the likelihood of an outbreak. So you keep quenching fire here and there and running helter-skelter, waste of resources and time. So those are my submissions. Thank you.
Thank you, Professor. There was a little bit of buzz on the line, but I think we heard very clearly. You said, speaking about the polio experience in Nigeria, if you can have strong surveillance, it helps you focus on where the most likely problems are. It helps you get ahead and it helps you plan rather than being reactive. Next, we have also from Nigeria, we have Celestina Obiekea. Celestina, would you like to jump in and give us your view?
Yeah. Hello, can you hear me now?
Yes, we can hear you.
Okay, hi everyone. Just as a writer from what Prof. Onimisi has said, and to give some context into the situation currently in Nigeria right now, and part of the reasons why I also picked that surveillance is one of the areas we should prioritize. So yes, there's a bit of information given from the previous outbreaks that we have had in the last 3 years. So we have an idea of the timing or based on seasonal differences and when the vectors are more in the environment because of the rainy seasons and all of that. But even at that, we still see that the index of suspicion is still low kind of from surveillance. So a lot of the outbreaks that we have seen in Nigeria in recent times have been, the origins have basically been after people have started dying, then you have reports of unknown deaths. So there's always that caption of unknown deaths. So now the way we kind of suspect is when you start hearing about cases of unknown deaths from febrile illnesses, then we start to suspect yellow fever. Why can't we, like Prof. Onimisi said, we can easily forecast, and know that around this time of the year, anytime from July, we start to see cases. And there's no need for us to wait until we start to have unknown cases, and we're putting a lot of pressure on the lab to quickly confirm cases, and we're doing outbreak response. Everything is always reactive. So surveillance really is a key part to this entire puzzle that needs to be strengthened in the coming years for the I strategy. Over. Thank you.
Thank you for that. It seems to be reflected if I go to question 2, which is which areas do you think you or your organization could contribute to the most? Same thing. There's a majority, 51%, that chose surveillance. What I'd like to do for this one, though, is for the second question, ask somebody who chose one of the less popular topics. In this case, the least one was IHR for yellow fever. And I'd just like to hear if somebody would like to come in and speak very briefly to that. We literally have 1 minute. But if you can make your elevator speech, your very short sentence explanation for why you think that area is key. Could somebody put up a hand? Drop your hands if you don't want to speak about this one. Put up your hand if you do. And if you want to speak about why you chose IHR for yellow fever and why you think that's a priority. This is your chance to advocate to your colleagues. Just stand by to see if some new hands go up. Looks like we have Luke Nkinsi. Luke, would you like to explain your view on IHR for yellow fever? Over to you. You might need to unmute yourself.
I didn't pick that one. I picked surveillance. I didn't pick that one.
Is there somebody who wants to speak? Hang on there, but is there anyone who'd like to speak? Don't be shy, because if we've got 19% of 111 people that chose it, there's still a good number of you who are interested in discussing IHR for yellow fever. If not, we'll come back to you, Luke. Just hang on a second to see if somebody else's hand goes up. All right, I don't want to take up too much time. So clearly, surveillance, surveillance, surveillance. Over to you, Luke, for your thoughts on, oh, wait a second, sorry about that. Jane Maina. Jane, do you want to come in on this one? Jane Maina. And unmute yourself if you're not automatically unmuted, please.
Thank you very much. This is Jane Mainam from Ethiopia Country Office. The reason why I think yellow fever needs to remain on the IHR agenda is that a lot of times yellow fever is considered like a traditional outbreak-prone disease, and so it is overtaken, usually overtaken by other newer or epidemics. For example, while we've had a lot of point of entry screening or checks for yellow fever vaccination, this has not been the case, especially during major outbreaks like what we are having in COVID. So there is more interest in checking if you have a COVID-free certificate. And I don't see progress into maybe another desk checking if you have a yellow fever certificate now. I've traveled quite a bit within the Eastern African region in the recent past, and yellow fever certification is almost a forgotten thing. Maybe something that people think should be picked after COVID. So this is one reason why we need to insist and enforce the significance of yellow fever on the IHR agenda. Thank you, and over.
Thank you, Jane. We're just about ready to start the next session, but my introduction is really quite brief, so we have time to chew into that. And Luke, I'd like to come back to you so you don't feel rudely interrupted if you wanted to come in and speak either on surveillance or one of the other areas that you feel is a priority.
Yeah,
Over to you,
yeah, this is Dr. Luke Mkisi, Senior Technical Advisor for PATH in DRC. So based on our most recent experience dealing with the largest measles outbreak in the world, so APIC surveillance and strengthening routine immunization, actually that two-pronged approach help us, control the most recent outbreak.
And why is that? Why was it? How did they help in particular?
Well, I mean, surveillance is key, but also because, for many, many years, I don't know if you're familiar with DRC, I just came here about a year ago. So routine immunization was very weak. So we used that two-pronged approach, strengthen routine immunization because it's integrated. The yellow fever immunization is integrated within the routine EPI immunization program, but it was very weak. So we used that two-pronged approach, surveillance and strengthening routine immunization.
So it's not one or the other. You need many of these elements in concert. And yes, I have.
At least those two. I mean, those are the two that we use, and it was very successful.
Thank you. I think we will move on to the next session now. I think that worked really nicely, colleagues, and thank you so much. One of the things Professor Luke did just now was introduce himself, and if all of you could please follow his excellent example as well, so that colleagues who don't know you will get to know you better as we go through. So this next session, we're already into session 2. This one is a regional overview. We're going to hear from AFRO, we're going to hear from PAHO, and we're going to hear from EMRO. After each region presents, we'll then have a discussion. In some of the other sessions, we'll cluster all the presentations together and then have a discussion. But this time it will be a discussion session after each of the presentations. So after our Afro colleagues speak, we will then have a chance to discuss what they have presented. And this time we will ask you to go over to Slido and ask your question there, or if a colleague has already asked a question that you think is good, you can like it so that it goes up higher in the queue, and then that's the question that we will ask the panelists. So it'll be slightly different. You won't have a chance to speak yourself, but you will have a chance to have your question answered. So for this session, the objectives are to understand the regional perspective and update on countries' needs and challenges in yellow fever prevention and control. To provide regional implementation updates, including country plans, and to foster some of that cross-regional collaboration that Laurence mentioned in her introduction as well. So our first session is over to our colleagues Ambrose Talisuna and Richard Mehigo. Davicho Afro, over to you, colleagues.
All right, so thank you very much, Nika, and thanks Laurence and others. Last year when there was the meeting, the annual I meeting in Brazil, we were all expected to meet together this year in Africa, and I think we are all planning to meet in Uganda for these partners. So unfortunately, COVID situation came in, and at least what is more important, we are having this opportunity to get this discussion virtually. But I hope that we will have another opportunity to welcome the I partnership in Africa in the near future. So I'm going very quickly to give you a progress in the implementation of the strategy on the African region. Next slide, please. So I don't want to spend much time on this. I think we have all know that yellow fever cut across not only some part of Africa, but also in the America. And despite having an efficacious vaccine now, the disease is still preventable and unfortunately endemic in close to 40 countries in the world. More recently, we know very well the progress that we have gained over the years have been quite put at risk, and the population immunity level really continued to wane, and we saw quite a big reemergence of outbreaks, particularly in West Africa at the beginning of the years 2000. So with the collaboration between partners, mainly WHO, UNICEF, and Gavi, the Yellow Fever Initiative was launched in 2006 and was able to launch a campaign drive across many countries in West Africa that has really helped to contain the resurgence of the disease and to put, at least for a certain period of time, the disease to a stop. However, we saw that after the containment of the outbreaks in West Africa, was a kind of a move of the situation in central and eastern part of the Africa. And the latest huge outbreak occurred in Angola and DRC in 2016 and 17, which really required a massive campaign both in Angola and DRC, and which highlighted some of the fragility of the system, particularly with the supply constraint that we saw. And I think that has really helped to at least bring the international community together to come up with this I strategy. Next slide. So we all know the three key objectives of the I strategy: to protect at-risk population, to prevent international spread, to rapidly detect cases, to confirm and contain outbreak. It's not a surprise that surveillance, that the small exercise that we have just concluded, really came as a top on the list of the issues that potentially we need to tackle to contain yellow fever outbreaks. Next slide. So what are the milestones that has been achieved so far in the African region in the implementation of the I strategy? So as of end of 2019, I'm really happy to report that all at-risk countries have initiated the implementation of the I strategy in the region. From one laboratory which were able to confirm yellow fever cases in the region for almost the last couple of years, we have now reached to 3 reference laboratories that are currently functional and have the full capacity for confirmation. All high-risk countries will have introduced yellow fever vaccination into routine. This was one of the key milestone, and I will come back to that. It was also meant to have preventive mass vaccination campaign to be completed in 3 countries, and will be initiated in 2 additional countries, and I will give some update on that. And the aim of the strategy by 2022 is to have 6 sub-regional labs to make sure that 6 out of the 13 high-risk countries have completed their preventive mass vaccination campaign, and all high-risk countries have established a diagnostic capacity for yellow fever. Next slide, please. So, what has been done so far in terms of the initiating the implementation of the I strategy in the region? So, first of all, in terms of the number of countries that have, which should have had a I implementation plan, we had 13 countries that were targeted so far. So I'm glad here to report that 12 of those countries have at least completed their development of their I implementation plans. These are the countries that you can see highlighted on the map. Out of those 12 countries that have their implementation plan, 4 have completed those plans, and these plans have been validated by the Ministry of Health. I think this is really a major milestone: Angola, Congo, Ethiopia, and Gabon. And we have 1 country that have yet to complete its development plan. This is Chad. But this has been mainly driven by the delay caused by the COVID-19 situation. Next slide. Routine immunization, I think it was also highlighted as one of the important area on which we need absolutely to work on, because as we know, the routine immunization is the one that is going to give the foundation of building population immunity. So if we looked at the map, mainly focusing on Africa, you could see that the majority of the high-risk countries have introduced the yellow fever vaccine into routine. We still have a few countries that have yet to introduce. Those are the ones that are in gray, and Kenya have introduced the vaccine partially. But when we looked and compared the coverage of yellow fever vaccine with the measles vaccine, 2 antigen that are currently given at the same time, some progress, I must report, that have been done so far. We have seen really country catching up the coverage with yellow fever compared to the measles first dose, containing vaccine first dose. We are yet to progress in terms of reaching a parity between the 2 antigen. That is important really to say that the effort that has been conducted recently are really starting to pay off. Next slide. Surveillance is still very unequal across the different countries. If you looked at this table, I'm sure it's very difficult to look at that, but we have tried at least to summarize what are the key indicators that we are following up in terms of surveillance across the different countries. In green are those indicators that are met, and in the purple color, this is the indicator that are yet to be conducted. So really pleased to see that this should remain one of our priority moving forward, because we believe that particularly in this region where surveillance for vaccine preventable diseases are mainly riding on the polio surveillance infrastructure, and with the certification of polio-free status in the African region, I think we will need definitely to find a way on how, while the resources of GPI are going to go down, this is not going to put at risk surveillance for yellow fever, but also for other vaccine preventable diseases. Next. I think we can jump this one. Next slide. So in terms of lab capacity linked to surveillance, though we believe that some progress needs to be done in this area, The data that we have is showing that the majority of suspected cases that were reported the last 9 months have their case investigated with blood sample collected. But we know very well that out of those 5,000 suspected cases that were collected, notified by member states, probably this is the tip of the iceberg, because sometimes we have a lot of issues in countries in interpreting the case definition, mainly at the field level. The example of Nigeria, and we heard our colleague from Nigeria mentioning that most of the time, it's only when death of unknown origin are reported in the community that when we do surveillance and lab confirmation, then it becomes a yellow fever situation a posteriori. So we need absolutely to see how to improve this area, not only case detection, but also for those who are arrive at the lab, they should come up with a good lab blood sample collected on time. Next. So with regard to laboratory, as I mentioned in the first slide when we were talking about the different milestones that were meant to be reached by 2019, I think we had the milestone of 3 regional laboratories. This has been achieved. I'm really, really happy here to report that beyond the Institut Pasteur of Dakar in Senegal, we have now 2 additional functional labs, the Centre Pasteur du Cameroon in Cameroon, as well as the Uganda Virus Research Institute. So these regional labs are now up and running, playing the role of decentralizing the laboratory capacity and try to give some space to the lab in Dakar, which was really overwhelmed, particularly when it comes to outbreak period. We are currently in discussion with our colleague in Nigeria to see how as well lab in Nigeria can be strengthened so that we can have as well and all the capacity to have a regional type lab in Nigeria as well. Next slide. In regards to preventive mass vaccination campaign, I think Laurence alluded to this slide in her overall presentation, so I won't take much time on that. Just to tell you that despite the COVID-19 situation that we went through pretty much since the beginning of the year, countries like Ghana, Nigeria, Uganda were able really to conduct outbreak response. That was the case as well in South Sudan and Ethiopia. But in terms of preventive mass vaccination campaign, we just concluded the campaign in Ghana. Nigeria is yet to launch its campaign. We are planning another one in DRC in the coming month. So I think it's refreshing to see that at least the momentum has been maintained, because it is a kind of multi-year schedule, particularly in the big countries like Nigeria, to make sure that all at-risk population are covered during this period of time. So preventive mass vaccination campaign alone will not solve the problem. I think we need absolutely in the meantime to make sure that we are strengthening the routine immunization, and where necessary, some catch-up campaign can be done to make sure that wherever there is a gap in immunity population, this could be filled quite rapidly. Next slide, please. So to conclude, dear colleagues, I would like to say that despite all the issues and problems that we went through in 2019 in the African region, COVID-19 vaccine, COVID-19 pandemic, measles outbreaks here and there, Ebola outbreak, yellow fever remains really a priority for us, because we believe that this is really a high infectious threat that could specifically threaten central, eastern, and southern parts, where we know very well that vaccination coverage remain low. Secondly, we need to make sure that the I strategy come up timely to support countries. And I would like here really to recognize the contribution of all partners in protecting countries in implementing the 3 major strategies of the eye. Here we would like also to call upon the partner to join the efforts of member states to improve immunization activities in the region, to strengthen surveillance, to reinforce laboratory. But as we have seen, particularly during the measles outbreak response during this COVID-19 pandemic, to prepare countries to be more agile when they are responding to any outbreak, I think will be really key. And then finally, we are really looking forward to see how we can establish a much more resilient program for yellow fever in Africa, so that we can make sure that the major outbreak that we have seen in the past are going to remain something in the history, and then we can move ahead really with a bit more resilient program that could prevent and save lives in this continent. So thank you very much.
Thank you so much, Richard. We have a few questions that colleagues have dropped into Slido for you, so please stay on the line, Richard. We'll come right to you. The question that got the most votes, which is the beauty of Slido, you can vote up the question that you want to ask, is the eye strategy integrated with vector control programs in Africa to have a faster response to outbreaks? Richard, how would you, what's the situation? What's the standard in some of the African countries?
Well, thank you, Nika, for this question. Unfortunately, in many places, that's not yet the case. And we have seen that during outbreak response investigation. And I think we've made it very clear when discussing with countries that those are the 2 sides of the same coin. I think to control more efficiently yellow fever outbreak, we need also to add element of vector control. So we are trying to push really towards that integration of both activity related to increasing immunity, increasing coverage, but to get a long-lasting effect and impact to controlling yellow fever, we need as well to invest in vector control. So this is an area that we need absolutely to work on moving forward. We are looking for the contribution of all the partners to support country in that regard.
Thank you for that. I think we're going to go to the PAHO presentation, and then we'll be able to have discussion after PAHO and then discussion after EMRO. So we'll have a chance to speak more as well. But again, we want to keep close to time so that we have a chance to hear everybody. So I understand the next 2 presentations are going to be on video. I don't know if our colleagues have been able to join us as well, but the PAHO presentation is going to be on video. Let me just double check here. So if you look in your agenda for PAHO, we have presentations, or the colleagues representing PAHO are Alba Maria Ropero, Jairo Mendez, John Fitzsimmons, and Sylvain Adighieri. Hi, Sylvain. So we will go to their videos now. And then, as I say, colleagues, please hop over to Slido if you have questions. Look at what other people have raised as a question. Add your own if you don't see something that you think should be answered, or vote up the ones that you think should be answered. So over to the next video, please.
Good morning. On behalf of the PAHO Health Emergencies Department and our Deputy Director, Dr. Sylvain Adighieri, I want to thank the organizers of the eye meeting for the opportunity to present some important aspects of the yellow fever situation in the Americas. As you know, there are 13 countries at PAHO region considered endemic for yellow fever, and cases have been reported sporadically for more than 16 years. These countries in the Americas are continuing to take great strides in research and understanding of yellow fever on a wide variety of aspects, including environmental factors like altitude, temperature, rain, and non-human primate distribution, as you can see in the slide. Between 2015 and 18, cases were reported by different countries. Nevertheless, The intensified transmission started in Brazil by the end of 2016, lasting for almost 2 epidemiological periods, was unexpected and the biggest outbreak in the recent history of Brazil, reminding us the potential of widespread and rapid viral transmission from the selvatic settings to urban areas. However, the experience and success of Brazil and the Ministry of Health to understand the transmission patterns and take actions to respond and protect the population have provided a unique opportunity for expanding the global understanding of yellow fever disease and control. There has been improved understanding of transmission dynamics and patterns and risks, including the movement of non-human primates through large selvatic corridors connecting separate geographic areas, the coexistent habitats in the border or peri-urban areas, where the selvatic and the urban environments merge, and even the role of different reservoirs that might be involved in maintaining the transmission. Thanks to the action in public health, including intense vaccination campaigns and a solid surveillance system, the situation is currently under control, and only sporadic cases have been reported during the last season, including episodic in Sao Paulo, Paraná, and Santa Catarina. As a final note, we know about human laboratory confirmed yellow fever cases and severe cases only, but not all the suspected cases. In endemic countries, most of yellow fever episodics are not studied or detected. Yellow fever vaccine is available. However, immunization coverage can be suboptimal in some areas. Co-circulation with other arbovirus, including flavivirus that challenge the clinical diagnosis and the lab confirmation, is still a problem and a challenge here in our region. The risk of urbanization is still present, as Aedes aegypti is everywhere. And one of the biggest lessons that we had from the last years in Brazil is that in the Americas, the history of yellow fever tends to repeat itself. Thank you very much.
Thank you for that presentation. We have another presentation from Pajo as well. If we could line that one up, please. Just stand by, colleagues, for the next one. I understand the next one is a video presentation.
Good morning, good afternoon to all participants in this I Strategy Annual Partners Meeting. Vaccination against yellow fever is a priority in all endemic countries in PAHO. They have introduced the vaccine into the routine program since many years ago, and they also have conducted different strategies in order to reach high-risk populations, such as campaigns, vaccination of travelers to exotic areas, vaccination of high-risk workers and migrants. This has been in coordination with many sectors and actors. The result of this intervention is reflected in a very low incidence of yellow fever and also small outbreaks. This is despite of large populations living in exotic areas. However, countries still have faced many challenges in order to maintain the control of yellow fever in the region. The intense yellow fever circulation in Brazil from 2016 to 2018 was a regional and global crisis in the middle of very shortage of vaccines. And then the country had to conduct a fractional dose campaign in order to reach large populated areas such as São Paulo, Rio de Janeiro, and Bahia, and in a very short time. Also, countries in the region have faced many challenges with vaccine availability for many years now, resulting in the accumulation of susceptible populations. We will be discussing this topic a little bit in detail in the next session. But the most important point that I would like to highlight here, that this was before the pandemic. Now, in the context of pandemic, this situation has been worsened. The vaccination coverage has been declined sharply, and then countries have to develop different strategies in order to catch up. Very innovative strategies are needed in order to close this immunity gap as soon as possible. And PAHO will be working with countries in order to support them in these initiatives. This is all for me right now, and then see you in the next session.
Thank you. The session she was referring to is characterizing and filling immunity gaps in PAHO. You'll see that on your agenda coming up. So now we have, just one moment. I thought we had one more presentation. Do we have a few slides? One moment, please.
From John Fitzsimmons. Oh.
Hi, Chair, if you allow me, I'll share my screen.
Please go ahead.
Can you see my slides?
Yes, we can.
Great. Apologies for not.
That's okay. You just might want to switch to presentation mode.
Yes.
And then you're good to go.
Apologies for not having time to submit a video along with my colleagues. I'll quickly move through these slides on the revolving fund. So in this first slide, you have a overview of the variability between the demand requirements of the PAHO member states receiving yellow fever vaccine through the revolving fund. In the orange, the offers made by the various suppliers during the course of the years that are shown here, 2017 through 2020, and what was actually procured. And to the right, you have a summary of some of the tendencies during the period 2017 to 19, including the support we received from UNICEF in 2017 to realign their supply agreements to allow for us to, at PAHO, to take on an additional 10 million doses to meet the demand that year. In 2018, availability was reduced as well, given supplier issues. 2019, we were still relying on one supplier, but eventually the second supplier returned to the market. And during 2019, our TAG meeting, organized by our immunization program, stressed the importance of achieving vaccination coverage levels at 95% in endemic areas through optimal routine immunization and campaigns. For 2020 and 21, as Alba Maria mentioned, we've been impacted in her video. We've been impacted with COVID. As you may imagine, there's been slow uptake of demand, cancellations, campaigns postponed, etc. We're projecting procurement this year of 6.8 million doses. This is complemented by an additional 5 million doses donated from Brazil to Venezuela, Panama, and Ecuador. And the details of those donations are shown here. This second slide refers to the endemic countries, the 13 or so endemic countries, and their procurement history over the years through 2020, and a look ahead at 2021, and the demand of about 8.8 million doses. In addition, over the last 6 weeks or so, PAHO supported Ministry of Health Brazil's interest in returning or making available 3.5 million doses that it received from the global stockpile back in 2017. And those doses were made available to DRC Congo at the beginning of this month for their campaign. Finally, just to highlight one of the other risks that we look at as a revolving fund and working with our countries, as all countries are responsible for their national budgets and financing of yellow fever vaccine, as well as the other antigens in their national programs. So on the left, you have a trend line here between May of 2019 to October of 2020, showing the number of countries that are in good standing to the revolving fund. This is shown in green. The number of countries that are in debt or arrears to the revolving fund, and we define debt as not having paid their invoices within 60 days of receipt of those invoices. So on the right, we have a simplified table which shows those countries that are endemic, that are in good standing, and those countries that are not in good standing, and the extent or the time period associated with their debt. This is a continuing challenge for our countries, exacerbated by the situation around the pandemic this year. We continue to work closely with all of the countries shown in yellow, orange, or red to find solutions to their particular problems and to clear those arrears so they're in a position to purchase vaccine when it's required. We're still in the process with Alba Maria of incorporating our risk assessment into the demand supply planning process. And I'll conclude with our next steps, namely the incorporation of those risk assessments into the annual demand plan. The risk of inaction, as Hiro pointed to, makes us susceptible to history repeating itself, i.e. with another serious outbreak. So our priority is to incorporate the risk assessments into our consolidated regional demand forecasts and to mitigate the financial concerns that countries are currently facing. Thank you very much for this opportunity to share these few slides. Over.
Thank you for that, John. So we're just looking over in Slido to see if colleagues have dropped in any questions on this session. I know it's a bit complicated, but once you get the rhythm of it, I think you'll enjoy being able to sort of engage on the questions and make sure that your question is coming through. If you have trouble using Slido, just look back in some of the messages you've received from the iSecretariat, and there's a link to Slido, there's the password there, and that's how you can get in and submit your questions. And don't feel shy. This is the way you can get your interests addressed during the session. Let me see what we've got here. We seem to have one question for this session. And John, I don't know if there's other colleagues from PAHO on the line, or it may all be on your shoulders. The current immunization campaigns in the Americas are using the yellow fever fractional dose of the complete dose, question mark? So, did you get that, John?
Good morning.
Go ahead, Alba.
Thank you. Thank you, Nika. Yeah, thank you for the question. The yellow fever campaigns are done with a regular dose, the standard dose. The fractional dose was only used in the case of the limited vaccine, a big outbreak in Brazil. That was the only one, the only time that we have done this strategy. Thank you.
Thank you for that. And let me just see. We also had some discussion ahead of time, knowing that sometimes it takes people a little while to get used to new technology. So we did a brainstorm ahead of time to think of what kind of questions we could ask during the discussion period. Let me see. How about this one? How does PAHO plan to supply the vaccine and meet the funding needs, if there are any, to meet the needs to fill the immunity gap? Or do you prefer to address that when it comes to your session, Alba Maria?
It's okay, but you can elaborate a little bit in the funding gaps as well. John?
Yeah, no, so this is a challenge for all countries, as we highlighted in the slide there. We continue to work closely with them to address those. With the advent of the pandemic, it's only been accentuated. To give you, as you can imagine, we benefited this year, of course, from the donation by Brazil. The countries that were shown with the serious arrears, i.e. greater than 90 days, those are where we're focusing our attention. One of the key tools that we have is our ability to extend our credit line. And so with one of those countries, and all countries are eligible to use up to $10 million at a time from our credit line. In some cases, that's been expanded to $30 million, and that's what we're currently confronting. And in order to negotiate that properly, we need to have an understanding and a commitment from those countries that are requesting additional credit to go ahead and purchase yellow fever vaccine or any of the other antigens that they may require, rotavirus, pneumococcal, et cetera, that we have a confirmed payment plan of when PAHO and its revolving fund can expect to receive the payments that are due. And so that generally requires, in this instance, not just the sign off of the Ministry of Health, but the Ministry of Finance. Over.
Thank you. Alba Maria, did you want to address that one at all? That part of the question? I can repeat it if that helps. Let me go to another one, actually. You're on mute, Alba Maria.
Oh, I'm so sorry.
There you go. That's okay.
Yeah, I was saying that we are working with countries in order to update their plans and also to see the financial situation, as John mentioned. But the most important part here is the countries are maintaining yellow fever as a priority, and then with that we can address later on the plans and vaccines. And the good news here is that we have vaccine available to meet the country needs at this moment. Thank you.
Thank you so much. Let me just see if there are any questions. Colleagues, in the chat in Zoom, you can see the link to Slido, if that's helpful to you. We have a question from the floor. Brazil shared some beautiful work regarding projecting outbreaks based on zoonotic NHP surveillance. Is that still going on? What can Afro learn from this? So I guess it's not so much, it is still a question for PAHO, with opportunities for Afro to learn. So I'll repeat the question because I jumped around a little bit there. Brazil had shared some beautiful work regarding projecting outbreaks based on zoonotics and NHP surveillance. Is that still going on?
Jairo, are you connected? Maybe I can say, if Jairo is not here, that yeah, Brazil continues working beautifully with the surveillance, episodic surveillance, and other kind of tools and strategies in order to strengthen the surveillance. And they are sharing all of these materials. And there are some colleagues also from Brazil connected here, and they're gonna present later on as well. Over.
Thank you. Yes, we have a session coming up later where we will hear presentations from Sudan, Brazil, Nigeria, and Ethiopia. And there'll be a chance to discuss then as well. I see a suggestion that Enrique Perez might want to respond on this question as well. Enrique, are you able to connect? Are you there? Just going to see if we can facilitate him joining if he's online.
Enrique, can you unmute yourself? Okay, that's fine.
Yes, I can. Can you hear me?
We can. Please go ahead,
Yes.
Enrique.
Go ahead.
Okay, thank you very much for the question. Yes, I believe Brazil is continuing to, as Alba Maria said, working with the methodology in terms of prediction of the cases of yellow fever outbreaks. Basically, that they use is models in terms of how the disease is presented in non-human primates, and they follow those through the ecological corridors, and they predict the way that the virus is spreading into the non-human primate population, and the moment that the speed of the disease in the non-human primates, and when they can reach human populations, and of course, if there is an exposure, there will be a contact and potentially a disease. What is the other part which is beautiful with this is the combination of this with the geographical information systems. So if you combine the ecological settings, the ecological settings plus the density of the non-human primates, plus the information coming from the outbreak presentations in the non-human primates, if you combine this information, you can do predicted models in terms when the disease could reach the human population. I believe this is it's clear to you. If not, I'm here to give you more information. Over.
Thank you, Enrique. I think we'll go on to the next presentation now to try to keep really strictly to time. So far, so good. So let's not jinx it. And thank you so much, colleagues, for your cooperation so far. It's been excellent. So our next presentation is by Chiori Kodama from WHO EMRO on the overview for that region, and then we will have had all the regions we'll have presented by then, all the yellow fever affected regions.
Thank you very much for this great opportunity to update for the annual I meeting. This is a regional update from the WHO Regional Office for Eastern Mediterranean. EMRO is an integral partner to the I strategy with a range of high and moderate risk countries. The region has seen an uptick in arboviral disease outbreaks, and the yellow fever is a priority. Sudan, the sole high-risk country for yellow fever in the region, has taken great steps toward assuring population immunity in the face of marked challenges from other outbreaks to the political changes. The region has yellow fever moderate risk countries with shared borders to countries that are high risk and with recent outbreaks. There is eagerness in the region to improve understanding of risk and take steps to prepare and prevent yellow fever spread. As you can see in the map, our region has been experiencing multiple arboviral disease outbreaks. The Aedes mosquitoes are present in several countries in the region, and a number of countries have reported repeated outbreaks of dengue, chikungunya, and others, while yellow fever has been confirmed only in Sudan. However, this may be a case of underreporting due to a lack of surveillance and a good laboratory system in the region. Therefore, scaling up preparedness and readiness for mitigating the threat of yellow fever and other arboviral diseases transmitted by Aedes mosquitoes has been our priority work in EMRO. And the EMRO countries located in African continent, as discussed, Sudan is the only high-risk country, and two others are moderate risk countries, namely Djibouti and Somalia. And when it comes to implementation of the I strategy, there is an eagerness in moderate risk countries since they are sharing borders to high-risk neighboring countries. The recent outbreak in Ethiopia has further triggered their eagerness to take steps forward. Djibouti and Somalia being situated in the ecological risk zone of yellow fever, and there is a heavy population movement to and from these high-risk countries and areas. Then what moderate risk countries can do? General approach is strengthening the surveillance and laboratory to monitor trends in human populations and detect potential introduction early. Implement IHR strictly to prevent importation. Intervene quickly in case of epidemic amplification following introduction. However, in Somalia and Djibouti, country capacity including surveillance and laboratory is very weak. For example, Somalia JEE score in 2017 for lab was mostly score 1 or 2. Surveillance score 1 or 2, except score 4 for syndromic surveillance system, and IHR score 1. Likewise, Djibouti JEE conducted in 2018 showing that laboratory mostly score 1 or 2, surveillance score 1 to 3, IHR score 1, and other emergency preparation score 1. Therefore, establishing a good system is not easy for those countries due to lack of resources, complex emergencies, long-standing conflicts, and natural disasters. Then this year, already fragile existing resources are repurposed to COVID-19 response, resulting in completely no more room for scaling up yellow fever preparedness. However, the threat of arboviral diseases remain or even higher since integrated vector management activities during this year has been downsized, leaving only favorable environment to mosquito breeding. This is a key summary achievement and challenges since 2017 in our region. For the key achievement, strengthening surveillance detection system. Left photo is one of our publications which became available this year in September. This publication aims to provide the key components for the implementation of syndromic surveillance and event-based surveillance for early detection of cluster of Zika virus and other arboviral diseases such as dengue, chikungunya, and yellow fever transmitted by Aedes mosquitoes. Other major achievements are enhanced IBM activities, such as supporting countries for vector control project, scaling up laboratory diagnostic capacity, including training of laboratory technicians and procurement of diagnostic supplies and reagents for lab. However, there are lots of challenges still remain, because confirmation of yellow fever requires a combination of good surveillance system, entomological surveillance, and a good laboratory diagnostic capacity. So we have identified inadequate entomological surveillance, lack of laboratory diagnostic capacity, which poses substantial challenges to proactively prepare and respond to emerging vector-borne and zoonotic diseases in the region. Regional laboratory networks also require enhancing and strengthening to facilitate logistic support, technical expertise, and data sharing. Also, continuous flooding and natural disasters, leaving more favorable environment to mosquitoes breeding. Conflicts, security threats, lack of resources. Those are the conventional issues for resource-limited countries in the region, but this year, COVID-19 has largely halted non-COVID activities, and our yellow fever preparedness plan for 2020, which was made in previous year, has been postponed till now. Vision for the future. To summarize our current situation with moderate risk countries, there is an eagerness to implement the I strategy in moderate risk countries in EMLO. However, there are challenges to implement the general recommended strategy for moderate risk countries. And then COVID-19 has halted yellow fever preparedness and response activities during 2020. Having said that, what we would like to propose for the forthcoming years, the development of I implementation framework in EMLO by mid-2021. Application of risk assessment tool for moderate risk countries in EMLO. Foster cross-regional collaboration and experiences sharing toward the framework implementation, which will be in parallel to development of the framework. I will end our presentation here. Thank you very much.
Thank you, Chiori Kodama from the WHO EMRO office. I understand we have some other colleagues from EMRO online. Hanan Abdo from WHO Sudan. Did you want to add something? I know we'll be hearing from you later, but did you want to add something at this moment, right after Chiori's presentation?
No, thank you. Hello?
None for now, okay. We'll hear from you later.
Okay, thank you.
Just a few things. Some people have reported a bit of a problem with the French translation, that they could hear some leak of the English presentation at the same time. Other colleagues have said it's fine, so I'm just flagging that to the interpretation board in case there's anything that can be done. Also, it's not you, don't adjust your set. There was some of that previous presentation, the quality of the video made the PowerPoint a little bit fuzzy, but I think we could all hear our colleague very clearly, and that's what's most important. Another thing to bring to your attention, it's also in the links you were sent beforehand. In the WHO Events app and the Dropbox, you can see some materials. For example, Benin has submitted a very nice poster on laboratory. So if you'd like to take a look at that, please do. So we don't seem to have any questions. Now there's 175 participants right now, which is excellent. And we do really encourage you to go over to Slido to drop your questions in. That's the only way that we can really interact with you at the moment. And I think we haven't had any yet. So we will look again at the questions that we worked on ahead of time. And I'm not sure who is online. Hanan, you might be taking all the questions for your region. So I won't hammer you with too many, and we can go to a break next. So the first question we thought of was that there was mention in the presentation of widespread arboviral disease outbreaks in EMRO region. Is there a surveillance and a laboratory network that specializes in these diseases, in arbovirus diseases? Hanan, if you can take that one.
Sorry, I can't comment for all the countries, but for Sudan, it is a part of the guideline that it is a package for all arboviruses and yellow fever. Whenever we have suspected case, we have the same case definition and it's tested for all arboviruses. And I think this is following WHO guidelines. So I'm expecting that it will be for all countries having the same guideline.
Thank you, Hanan. Are there other colleagues? Does anyone see if there are other colleagues from EMRO? As you're saying, Hanan, it's not fair for you in one country office to take the answers for the entire region. Yes. We have one we saw from Slido, which is what are some key lessons learned and best practices that could be implemented across regions, and how can the I Partnership best facilitate this? Maybe we'll just narrow it down for Hanan and see in Sudan, what have you seen that works well? What have you seen that you suggest other colleagues know about, yes, that they might want to replicate?
Actually, maybe EMRO is during the past 3 years is only focusing for Sudan. As I mentioned, Sudan is a high risk, and the experience that having the good guideline in place and good technical and financial support from I group, the whole Gavi for financial support. This is the main issue. Support is the country to have all strategies for the I in place for Sudan. So I think even for the countries, for the region, will learn from Sudan experience as the implementation of the 3 strategies is going well in Sudan.
Thank you, Hanan. We'll take you out of the spotlight for now. Colleagues, we've done well. We've earned a break, I think, so you can stretch your legs and have a tea. We're going to break until 1:15. And so I think that's a nice long break still. If you feel like sticking around a little bit longer, we're going to be showing a photo montage now, which is pictures of past yellow fever interventions in various countries. If you are feeling enthusiastic about the meeting and you want to share that enthusiasm with others around the world, there is a social media package you can go to, which has all the materials, the visuals, the hashtags, our social media handles that you can use to tweet about the meeting. I know that Dr. Fall has already tweeted about the meeting. So if you look in the resources again that you received earlier, and we'll see if we can drop that in the chat as well, it will give you all that you need in order to be able to tweet about the message. When we come back from the break, we'll be into session 3. We'll be looking at risk characterization, and then after that session, we will look at country presentations. So thank you, colleagues, and see you back here in 15 minutes. Over for now. Colleagues, we're coming back in 2 minutes. If you're online, just be ready to come back in 2 minutes. Colleagues, welcome back from break. Ready for the next session now. I hope you enjoyed the photo montage. There's some very inspiring photographs, I think, of work colleagues are doing around the world. And I think you get a bit of a sense of impact too when you see everyone lining up with enthusiasm to get this life-saving intervention. So as we said, going into the break, this next session now, we're going to be discussing risk characterization. Then we're going to have the country presentation, Sudan, Brazil, Nigeria, Ethiopia. We'll have a chance for discussion and then we'll close the day. I think we're going to look at seeing if we can hear more from you on the floor because I know there's things that you can't put into a question. And that might be easier to discuss if we have a more of an open session. So we'll look at doing that at the wrap up at the end of the day. So now we're into session 3B, which is called Best Practices for Controlling Risk. We have 2 presentations and we'll have a discussion at the end. Sorry. This is section 3A, risk characterization. We have 2 presentations and we'll have a quick discussion at the end. The objective of this session is to provide a global overview of factors contributing to yellow fever risk evolution and explore how risk analysis can inform programmatic rollout. And first we will hear from Nicole, I think with a PowerPoint, Nicole Lindsay, Risk Analysis Working Group and US CDC. Over to Nicole Lindsay.
Hello, boom, I think, there we go, perfect. Good afternoon, everyone. Thanks for the opportunity to share some of the work completed by the Risk Assessment Working Group. Next slide. One of the primary goals of this working group is to develop a simple to use and evidence-informed approach to assess risk of yellow fever in the 47 countries considered to be at high risk for yellow fever by the I strategy. These assessments are meant to provide objective input to support operational planning and to allow for prioritization of campaigns between and within countries. Next slide. Today, I'm going to focus on our work on the national level risk assessment tool. Next slide. To develop this tool, we began with a simple approach that involves awarding points for the presence of various factors that influence yellow fever transmission, with more weight or higher points awarded for more recent events. Of note, this tool is meant to estimate risk based on what we know, It's not meant to be a predictive tool in terms of locations or where the next outbreak might occur. We focused on key variables to help define endemic and epidemic yellow fever risk. I'll briefly describe the components of the tool shortly. Once a draft was developed, we pilot tested the tool with a few countries having recent transmission. The results of these assessments identified limitations of the approach, and options for adapting and improving the tool were then discussed with global experts on the working group and with in-country representatives. A version of the national tool developed for use in African nations was published in early October of this year. Next slide. So this slide outlines the current components of the national tool. They fall into three categories: endemic risk, epidemic risk, and mitigation. Endemic risk is a measure of baseline yellow fever virus activity and includes data on confirmed disease cases, as well as land cover data as a surrogate for the presence of non-human primates and endemic mosquito vectors. Epidemic risk is a measure of the risk of virus amplification and increases in disease cases, and includes time since the last confirmed cases in a country, confirmed cases in adjacent countries, epidemic mosquito vector presence, and some measures of population density and healthcare infrastructure. The last category, mitigation, reflects the estimated population protection from previous vaccination activities, both routine EPI coverage as well as preventive and reactive campaigns conducted. Mitigation scores are negative, so vaccination coverage decreases the overall measure of yellow fever risk. Next slide. I'll just close with a brief summary of our next steps. As already mentioned, the version of the national tool developed for use in African nations was published in early October. We have been engaging with other eye working groups to share the tool outputs to support their activities and potentially obtain better input data or direct measures of yellow fever risk. We will also be working to adapt the tool for use in the PAHO region. We expect to periodically update the data used to populate the tool as new data become available, and will continue to assess the tool for any update needs. We will also be working to finalize a draft subnational risk assessment tool. This work requires substantial engagement with in-country partners, which has been difficult in the past year given the pandemic and other competing priorities. Once we finalize the draft subnational tool, we will pilot test and work through an assessment process as was completed for the national tool. Next slide. Just to close, I'd like to acknowledge the work of all the members of the risk assessment working group listed here, and thank you for your time.
Thank you so much, Nicole. Colleagues, if you have questions for Nicole, if you have questions on this, risk characterization, please drop them in Slido. Please see if anybody else has put a question and if you'd like to ask, and we're going to go to the next presentation and then we'll come back for the discussion afterwards. So as Alba Maria indicated when she presented to us just a few minutes ago on the situation in PAHO, she had a follow-up presentation on characterizing and filling immunity gaps in PAHO. Back to you again, Alba Maria.
Thank you so much. In these 5 minutes, I will give you a brief presentation on vaccination coverage and gaps and challenges that we have in the region. Next one, please. These are the points I'm going to cover. Next one. In this slide, you can see vaccination coverage in children in Latin America and in the 13 endemic countries from 2016 to 2019. As you can observe that these vaccines, these coverage are underperforming in these countries, in this context. And then we have an accumulation of susceptible populations in all 13 countries in PAHO region. Even though I would like to highlight that in 2019, we had a little bit more vaccines and then there was an improvement in some countries. Next one. In 2018, we conducted a workshop, a risk assessment workshop, including the estimation of a susceptible population in the region with all countries and using historic data and cohort analysis for age groups. And then we estimated at least 100 million people to be vaccinated, susceptible populations living in exotic areas. Countries elaborated national plans in order to address these gaps. Next one, please. That was before the pandemic. During the pandemic, we had planned in 2020, we had 2 countries planning conducting campaigns against yellow fever, which were Bolivia and Colombia. This country had to postpone these campaigns in order due to the COVID pandemic. Next one, please. Now, the impact of the pandemic and immunization program has been very negative, with declining of vaccination coverage in general. And on your left, you can see here the measles rubella vaccine in 2019 in comparison with 2020, and you have the decrease at least 20 or 30 points in the vaccination coverage. And this is worse for yellow fever because it's not like Africa. I just was happy to see that in Africa, the measles, rubella, and yellow fever vaccines are very closely. In PAHO region, there is a big difference in these 2 vaccines, even though we recommend to administer the vaccines simultaneously, these 2 vaccines, but there have been some changes in the schedules and then yellow fever is behind. On your right, you can see here the yellow fever vaccination in Brazil in 2019 and 2020, and you see in the red bars the decrease in the vaccination coverage. That is important to know what is in each country in order to address these gaps. Next one. Now, we as PAHO recommended countries, and we issued several recommendations this year in order to strengthen the routine program, and especially those vaccines which are prone to epidemics such as yellow fever, in order to maintain the vaccination using different strategies and innovative strategies to reach these populations. They use different approaches such as vaccination by appointment or vaccination and mobile teams or drive-through. Also here, I would like to highlight something that John Fitzsimmons mentioned, was the donation of yellow fever vaccines to 3 countries, and especially 4.7 million doses to Venezuela. That we analyzed this situation last year in Brazil, and we highlighted the importance to support Venezuela, and now they started the vaccination on 15th of November, last week, actually. They started the vaccination against yellow fever in 10 endemic states in Brazil. As an additional information, I would like to share with you also the Biomanguinhos, which also always produces vaccine vials for PAHO regions of 5 doses vials, which are the preferred option for countries. That this presentation will be suspended, and they will continue working on 10 vials for yellow fever, given that they have to use this infrastructure to produce COVID vaccines. And then this is something new also as an impact of the COVID vaccine situation. Next one. As a next steps, as I mentioned, the importance of maintaining immunization as an essential service, to continue to evaluate the impact of the pandemic on yellow fever at subnational level especially, and to update national plans based on the routine, the risk assessment and the accumulation that we have. It's a higher accumulation right now. And also to take advantage of any opportunity to vaccinate yellow fever using measles campaigns, or during the routine giving these 2 vaccines simultaneously, the yellow fever and measles rubella vaccines, as is recommended by our NITAC and also by WHO. And also we have to continue to improve the data quality and the electronic register for vaccination against yellow fever, among others. Thank you so much for your attention.
Thank you very much for that. So now we have time for discussion, colleagues. We have 1 question at the moment. Please feel free to drop in some more in Slido. This question is actually for you, Nicole. just to say she's not able to put on her video for connection problems, but she's here, she can hear you. Nicole, the question for you was, is there any plan to develop a harmonized, oh, sorry, here we go. First question, what is the timeline for the draft subnational tool? First question for you.
Yeah, that's an excellent question. And I don't know that we have a hard timeline on that. I would say we are aiming probably for some time in the first quarter of next year. Aaron, I don't know if, Aaron Staples, I don't know if you have any further input on that question.
Yeah, thanks, Nicole. This is Erin Staples. I'm the work group lead for the risk analysis working group. We did discuss last week with the work group members the components of the subnational tool. I think it really is a little bit up in the air because it is going to require several countries kind of engaging with us and understanding competing priorities. It is, you know, with COVID and other outbreaks, we'll just have to see how it goes. But we would be optimistic and hoping to have something available, as Nicole mentioned, in the first quarter of 2021.
Thank you both for that. Also for Nicole, I think, is there any plan to develop a harmonized risk assessment for all epidemic and endemic countries in the world, not just for Afro and PAHO?
I believe that the focus is for Afro and PAHO. I appreciate the question, certainly. I think that the tool is meant to be broad and flexible enough that it could probably be used in other countries as well, other regions, although it's not specifically designed to do so. And I guess, again, I'll let, if Aaron, if you have any further inputs on that.
Yeah, no, the tool was specifically designed with the I strategy goals, you know, first helping to prioritize vaccination as well as highlight risks in terms of surveillance, strengthening of laboratory, but I do think that we could adapt or use it more broadly if called for in other regions. Over.
Thank you for that. We have a couple of questions that would be for you, Alba. There was a summary of, in your presentation, there was a summary of needs in high-risk countries. Is there a proposal of how these relative needs, how the needs will be prioritized?
Yeah, the idea is to update these plans based on the risk assessment, and then we can, or countries can prioritize regions. For example, in Venezuela, they already highlighted or prioritized 10 states within the country, and that will be based on the risk analysis and also with the accumulation of new cohorts which are not vaccinated here. We have a methodology. PAHO has a methodology, and Enrique is connected, Enrique Perez, in order to have a very updated risk assessment also with working with countries.
Thank you for that. I don't see any further questions at the moment. Just an update to say it seems the languages are working well, the translation is working well, the interpretation I mean, and thank you to our interpreters for being online to do that. It's wonderful to be able to do this even in this new platform, new-ish platform for everyone. I think we might just move on to the next session. We're slightly ahead of schedule, and we thank you, colleagues. It's because of you that we're able to be on time and hear everybody out and give the chance for everyone to present as they wish to present. And stay around for discussions at the end of the day. We'll try to be a little bit open and maybe it can be a little bit more fluid. I know Slido takes some time to get used to. So session 3B is the country's presentation, best practices for controlling risk. The objectives for this session are to showcase successes and innovations for reducing risk and controlling spread of yellow fever, and to highlight mechanisms that yellow fever control activities can synergize with other public health interventions. Just as we did in the session before, we're going to have a repeat performance, and we will hear from Hanan in Sudan. First presentation, then we will have from Brazil, Nigeria, Ethiopia, and we will have the discussion following all those presentations. Please drop your questions into Slido if you see other questions that you like them, and that makes more likely that those questions will be asked. So our first session, Hanan Abdo from WHO Sudan, please, over to you.
Okay, Assalamu alaikum, and thanks for giving me the chance. Greeting for all, long time since we have the last meeting. So I will start to give a briefing about Sudan. Next slide, please. Next slide, please. So I will give brief about commitment to eye strategy, risk of yellow fever epidemics, protect at-risk population, implementation of international regulation, and early detection of outbreak, and then the way forward for Sudan. Next. Sudan has been committed to eye strategy implementation since 2017. And all the three strategies started by implementation and being in place. The three strategy objectives as declared by the eye strategies to protect at-risk population, implementation of the national regulation for yellow fever, and early detection of outbreak are fully implemented in Sudan. Next. As we have mentioned previously, Sudan is ranked as a high-risk country, being allocated in ecological risk zone of yellow fever in Africa. And Sudan has conducted risk assessment in December 2012, led by WHO, concluded that yellow fever virus circulation confirmed in all parts of Sudan. And based on the WHO classification for yellow fever endemic countries in Africa, Sudan classified as one of the high-risk 31 African countries, and bordering with 5 high-risk countries: Chad, CAR, and Ethiopia, Eritrea, and South Sudan. Second, for activities conducted to protect population at risk, more than 32 million persons aged months to 60 years were vaccinated by yellow fever vaccine in all states in a phased manner. Some of Darfur localities has been covered during outbreak response of 2012 to 2013, and the remaining were covered by 4 rounds of mass campaign 2014 to 2019. South Sudanese refugees has been targeted and covered in most of the states. The vaccination targeted the population at risk and residents in areas that reported yellow fever outbreak in Darfur in the past, mainly Darfur and South Kordofan states. Closing the yellow fever immunity gap, Gavi exceptionally with all thanks approved Sudan request for mini catch-up campaign for 7 first cohorts, that is around more than 6 million children not vaccinated. The calculation is unique to each state based upon the year of implementation of mass campaign, and then multiplied by the size of projected per cohort. Yellow fever introduction routine schedule plan as single dose at 9 months age with MCV1. Launch will be in January 2021. In August 2022, August 2020, many catch-up was implemented in Wide Nile, covered more than 500,000 children, and in addition to more than 100 South Sudanese refugees, and a good coverage was achieved, and even the people not catch cold during the campaign will reached by mobile campaign after the campaign days. Next. Regarding the implementation of international regulations, Sudan has 22 vaccination posts around the country for yellow fever vaccination for international traveler, and the card is required by many countries. As a rule by public health regulation in Sudan, it is mandatory to screen for yellow fever vaccination and check the card for any incomer from any endemic country by any route or port. But this is not strongly applied. Next. For early detection of outbreaks, WHO with Gavi support has supported Sudan in update of yellow fever surveillance guideline as part of the viral hemorrhagic fever guideline. As SOPs for any hemorrhagic fever case, yellow fever must be laboratory test to be excluded. Sudan applied for Gavi yellow fever diagnostic and laboratory consumable procurement support, and the request approved and in process. The lab, in collaboration with reference lab in Uganda, and thanks to Maurice and thanks to all strategy group for their continuous support in Sudan and responding to all our requests and support. And up to date, for 2020, there were 4 suspected cases from South Kordofan state, all male, aged 7, 20, 33, and 55 years, and all were negative for yellow fever. The way forward for us is the implementation of yellow fever mini-catcher in the remaining 17 states in 2 phases. Introduction of yellow fever and routine vaccination in January 2020. Ensure yellow fever surveillance functionality and sensitivity. Ensure availability of functional yellow fever laboratory testing and operationalization of the screening for yellow fever vaccination and checking the card for any comer from any endemic country by any route or port. And we, as maybe some of you have been aware that now we have influx of Ethiopian refugees in the eastern part. And the problem is that eastern part is fully with Aedes aegypti, and this region suffering from chikungunya and dengue fever outbreaks throughout the year in the eastern region. And now we have Ethiopian refugees around 40,000 or more than 40,000 with daily influx to Sudan settled in this region. So there is a plan for availing routine immunization for all under 5 and having combined vaccination for other vaccine preventable disease and strengthen for them. Next. This from Sudan. This is our thanks to all support for Sudan in elimination of yellow fever epidemics, and thanks to all supporting for we have usually mentioned that Sudan is one of successful stories in Sudan is elimination of yellow fever. As before implementation of this mass campaign, Sudan is suffering a lot of many outbreaks with high mortality rate. Thank you.
Thank you very much, Hanan. Our next presentation is a PowerPoint presentation from Brazil with Noeli Fabiana Oliveira de Moura. After Noeli, we will have Nigeria, followed by Ethiopia, followed by our discussion. Colleagues, we have 50 minutes left to the end of our time together today. And so over to you now, Noeli.
Muito obrigada. Agradeço pelo convite. Meu nome é Noeli Moura, atualmente como coordenadora de vigilância de arbovirose do Ministério do Brasil. Por favor, o próximo. Próximo, por favor. Bom, a febre amarela ela é considerada endêmica na região amazônica, no Brasil. A ocorrência, ela é sazonal, com maior incidência entre os meses de dezembro e maio. Vou falar rapidamente sobre a situação do cenário epidemiológico atual, na sazonalidade de julho de 2019 a julho de 2020. Nós temos registrados, observando o mapa do Brasil, nós temos registrado 390 episodias de primatas não humanos, confirmado positivos para a febre amarela, todos concentrados na região sul do país, e são registrados 19 casos humanos, também registrado na região sul do país, apenas 2 casos humanos na região norte, que é uma região endêmica. No gráfico ao lado é a distribuição por sexo e faixa etária dos casos humanos de febre amarela, desses 19, no qual 18 casos foram do sexo masculino, correspondendo a 94,7% dos casos, e apenas um do sexo feminino. A distribuição de faixa etária predominante no sexo masculino foi 40 a 49 anos e de 50 a 59 anos, todos sem registro de vacinação contra a febre amarela. Por favor, o próximo. Para a sazonalidade atual, quando a gente faz o recorte de julho de 2020 a julho de 2021, então nossos dados hoje, novembro de 2020, nós temos registrados 19 epizootias confirmadas para a febre amarela, das quais essas 19 estão distribuídas no Brasil, na região centro-oeste, são 14 no estado de Goiás, 1 no Distrito Federal, na região sudeste, 1 no estado de São Paulo, e na região sul, no Paraná, 3 epizootias confirmadas. Por favor, o próximo. Então, quais são as principais estratégias do Brasil? Então, o Ministério da Saúde ele tem promovido iniciativas de modelagem de dados e avaliação de risco. Para quê? Para subsidiar a tomada de decisão e a prevenção de surtos e de óbitos. No Brasil, nós temos um grupo técnico com especialistas nacionais e internacionais para desenvolver esses modelos empíricos de predição. Então, com essa metodologia de previsão, dos corredores ecológicos, ou seja, dos caminhos de traçar as rotas de dispersão do vírus, esses modelos eles são baseados em dados de vigilância de epizootias, são baseados em dados climáticos e de vegetação. E assim nós conseguimos traçar esses caminhos de dispersão do vírus, ou seja, os corredores ecológicos, e aí definir as áreas prioritárias para vacinação e ações de controle em saúde. É importante deixar destacado que hoje todo o país, todo o Brasil é uma área de recomendação de vacina. Na figura, nós temos aí a rota de dispersão do vírus para a região sul do Brasil, no qual este modelo ele pode prever a velocidade de propagação do vírus e assim fazer projeções de datas. Então, nós temos aí nesse mapa as linhas em vermelhas, onde já são áreas com circulação viral evidenciada, seja pela presença de primatas não humanos positivos ou de casos humanos, ou seja, o vírus ele está circulando. Em laranja, a circulação do vírus que ainda não foi detectada, mas estão na rota de dispersão do vírus, ou seja, precisa de uma vigilância ativa de epizootias. E na linha em verde, são áreas que ainda não foram afetadas e a circulação do vírus da febre amarela ela é esperada. Por favor, o próximo. Mas, para gerar esses modelos de precisão desses dados, esses modelos de corredores ecológicos, esses dados, eles precisam ser precisos. Eles precisam ter a localização das epizootias de primatas não humanos. Então, o Brasil hoje, ela faz uma vigilância de primatas não humanos de forma ativa e com localizações precisas de epizootia, através desse projeto implementado em conjunto com a Fiocruz, no uso de uma plataforma que é chamada CIGEL, que é a Plataforma de Sistema de Informação em Saúde Silvestre, no qual o usuário, a população, o profissional de saúde, ele pode registrar a presença de um primata não humano em qualquer localidade e através de um aplicativo ele detecta a presença e através de dados de geoprocessamento é enviado para um registro nacional. Conforme esta figura, no lado direito nós temos o Brasil, mapa do Brasil com várias referências, ou seja, são vários pontos onde foram captados as imagens de primatas não humanos e assim a gente consegue delimitar a presença do vírus e a dispersão do vírus através desses corredores ecológicos. Por favor, o próximo. O uso dessa plataforma, que está em implantação nacional, ela busca ampliar a aceitabilidade e a participação do usuário para os registros de primata não humano e a notificação da epizootia, que utiliza esses registros em tempo real, permitindo assim a captação oportuna, ou seja, detectar oportunamente as áreas que precisam ser atuadas de vigilância em saúde, seja para vacinação ou para outras atuações. Então, através desse registro fotográfico do animal, que favorece a identificação do local de ocorrência, contribuindo para a qualificação da informação gerada pelos serviços de vigilância. Então, esses registros, eles precisam ser georreferenciados e aí, de forma oportuna, alertar as ocorrências e os modelos de previsão para emergência de saúde. E aí, proporcionar de maneira rápida e eficiente todo o fluxo de informação para a rede de saúde, para os governos, para a tomada de decisão. Próximo, por favor. Então, todas essas estratégias, elas são integradas, principalmente com as ações de investigação de campo, seja as ações de busca ativa de primatas e epizootias de epizootias de primatas não humanos, de casos humanos suspeitos, através de busca de indivíduos não vacinados, através de orientação e mobilização da população, principalmente dos profissionais e a população para a intensificação vacinal e assim atualizar esses modelos, atualizar essas modelagens de dados para as áreas de risco e atuar nos planos de ação. E é importante que dentro de todas essas ações, nós também temos estratégias de ampliação da rede de capacidade da rede de laboratório, com estudos de vigilância genômica, além das ações de vacinação e de controle vetorial, principalmente porque nós temos áreas onde temos a circulação da febre amarela e de arboviroses urbanas. Próximo, por favor.
Just a polite notice to say we have a minute left. Please interpret for me. Thank you.
Esses são os nossos parceiros do Ministério da Saúde que nos ajudam em todas essas estratégias. Agradeço e muito obrigada.
Muito obrigada, Noeli. Thank you so much. So, as I said, we will do the discussion after all the presentations. The next one is for Nigeria. We have our colleague Basi Okposon with us to give a PowerPoint presentation. Over to you, please.
Thank you. Good day, everyone. I'm making this presentation on behalf of the NPHCDA, and I want to also acknowledge the efforts and contributions from all our partners and other agencies and ministries that are involved. I want to appreciate the Federal Ministry of Health, the NCDC, our WHO, UNICEF colleagues, then our donors, Gavi, and the rest that have been supporting us, CDC. Next slide. Next. Now, just a background that the I strategy was launched here in Abuja in April 2018, and the country is focused on achieving the 3 strategic objective goals. And looking at the strategies, picking the one that has to do with the preventive mass vaccination, we plan to implement in 6 phases. 3 have been completed already, while the 4th is ongoing this year. So far, 63 million persons have been vaccinated in Nigeria. In our routine coverage, has been about 53% from UNIC, though the SMART survey of 2019, that is preliminary, is showing 71%. The I strategy plans was aimed at shortening the completion of the country vaccination by 2023 instead of the 2025 earlier plan. Next slide. Now, giving us information that looking at our country in 2020, the yellow fever risk categorization has 6 states as high risk, 27 as medium risk, and then 3 states as low risk. This is based on the yellow fever risk categorization that was done in 2019 October. And these are the areas we have: the red showing the high risk area, the yellow, the medium, and then the green, the low areas, the 3 states. Next slide. Just giving us a little information that we talked about the 6 phases. And these 6 phases, we had the phase 1 in 2013-14, phase 2 in 2018, phase 3 was in 2019. And then this year we've had plans, though we had COVID-19 outbreak in the country. This delayed the implementation in July, but as we are talking, the implementations are ongoing in about 5 states. Anambra has been completed. Earlier in the year, we also had Ekiti Rivers completed. So we have ongoing now Delta, Osun, Ondo, Benue, and Oyo State. The campaigns are ongoing. We have planned for phase 5 and 6 in 2020, 2021, 2022. And we also have this already approved by Gavi. And this will involve the states of Taraba, Gombe, Imo, Kano, Ogun, Ebonyi, Abia, and Borno State. Bauchi was to be done this year, but because of vaccines will be done January 2021. Next slide. Also, we'll know it will be interesting to inform this great house that in the last 3 weeks, there's an ongoing outbreak of yellow fever in 3 states of Bauchi, Delta, and Enugu State. This during the week of 2nd to 6th of November, these outbreaks were reported. We received the report from the Bauchi, Delta, and Enugu. But up till date, 47 deaths were reported in Enugu between June and date. And while from Delta, we had 32 deaths, and then from Bauchi State, 8 deaths were reported. All the deaths and current cases are ages 18 to 30 years and have never received yellow fever vaccines. The outbreak response is ongoing in all the affected LGAs since the 10th of November. And just to inform this great house also, the outbreak so far has been contained and we are not having new cases reported following the emergency vaccinations that are ongoing in those LGAs. Next slide. Now, sharing our best practices for controlling the risks of yellow fever in the country, we have key areas and improvement in routine immunization and the conduct of quality preventive mass campaign that have improved the health immunity in the country, and these have also contributed in preventing many deaths that would have occurred. For the sustained routine immunization, we have the SMART survey is showing about 71%, and we are very sure and confident that this has contributed to an improvement in the herd immunity. And then victims of the ongoing outbreak in the country never received the yellow fever. And we have seen also that the conduct of the campaign have also helped in preventing deaths, because in those states that we have already conducted the campaigns in the phase 1 to phase 3 and some that have participated in phase 4, the cases are reduced. We don't see cases in those states. And then even in few LGAs like in Bauchi that is involved, those ones that came down with the yellow fever never received the vaccine. And of course, there is also an improvement in the global vaccine supply. This has helped us in reaching more areas that we would have wanted to reach. Next slide. Then we also have the further develop the SOPs, and this is helping in the implementation. You know, with the COVID outbreak in the country, this was enough to have stopped the campaigns. It delayed the campaign, but it has not succeeded in stopping us in implementation. So we have commenced the implementations in the remaining 5 states that we plan to conduct using these SOPs that we have with the guideline. Next slide. Next slide. Then we also have, no, back of one slide. We also have here in Nigeria, utilizing the experience of integration in the planning and implementation of integrated yellow fever. This has helped us a lot. We have integrated in Anambra. We borrow from the experience of the integration we had in Anambra, and we are going to further do more of the integration to save resources, save time, and the time of the health workers, having integrated campaigns. Next slide. And then in the surveillance also, the yellow fever training working group continue to get yellow fever surveillance in the country. We have the IHR system existing in the country with the focal person as NCDC, and we also have our labs that at least the preliminary confirmation that are happening. From these cases, we will receive report from those 3 states. The labs here in country were able to give us the preliminary confirmation of what the issues are. The challenge we have here is that the reference lab is far away from us, but the other labs that are here are giving us early reports from the samples that have been taken. Next slide. Then for the key challenges, just to mention that we are planning for the campaign in 7 states next year, and 29.1 of the 50 million doses, 55 million doses that are available will be given to the country for next year from the approval we've received so far. This will cover those other 7 states except Kano. Just to inform us that the Kano itself, we have about 14 million persons, which will really still look for more assistance from the team to be able to, for us to be able as a country to also cover Kano for next year so that we won't be having these cases. And also, as mentioned earlier, we have as a country, we need a reference laboratory that will help us in early confirmation of these cases. And also the non-implementation of the non-human primate surveillance and entomological studies is a challenge. We also had disruption of the 2020 surveillance and laboratory activities due to the COVID-19 pandemic, and staff are involved more in the COVID testing than any other one. And as Richard mentioned earlier in the beginning of this meeting, the staff, most of them are involved, so we could only pick the cases when we started having report of strange deaths in some of these areas. And then the initial and delay in transportation of samples to the reference lab for some months due to the COVID lockdown in the country. Next slide. Now, our next step as a country, we just want to be focused and ensure that the phase 4 campaigns are completed in the remaining 5 this year. The outbreak response are ongoing. We'll finish and ensure that it is contained in those LGS and state consent. And then the engagement for the utilization of the second year of life opportunity to improve yellow fever vaccination in the country, and ensure that all the strategies of the the remaining 2 strategies are also implemented. Next slide. And we also have our long-term plans of improving and sustaining the yellow fever population immunity of all Nigerians and address any outbreak that might come. And increasing and sustaining yellow fever coverage to 80% and above, at least by 2022, we plan to do that. And then build a resilient system to support response to other viral diseases. Next slide. As a conclusion, Nigeria's goal is to have all Nigerians protected from yellow fever by 2023. Nigeria will continue to address the challenges that we are experiencing around the implementation of our strategy with specific focus on the 3 strategic objectives. With the accelerated eye strategy in Nigeria, we hope to have all Nigerians protected from yellow fever by 2023 and improve country capacity to promptly respond to all alerts and a robust laboratory network to confirm outbreaks in timely manner. I want to use this opportunity to thank everybody, our donors, our partners, for the support that you are giving to us. On behalf of the country, I want to say the last slide is just to say thank you to all of us for the support you are giving to us. Thank you.
Thank you, Basi, and thank you for the thanks to all the partners as well. Our next presentation is from our colleagues in Ethiopia. It's going to be a video presentation. And ready when you are.
Good evening, good afternoon, and good morning, colleagues. This is presentation from Ethiopia, WHO country office. So Ethiopia as a country, we find the history goes of yellow fever back in 1960s and 1960 to 62, whereby we find a record that there was yellow fever outbreak, a huge one. Around 100,000 cases were reported with 30,000 associated deaths. Then there was a lapse of around 50 years, but in May 2013, there was again an outbreak of yellow fever which was reported, and both these 2 cases were reported from Southern Nation and Nationality region of Ethiopia. And in the 2013, it was 141 cases and 43 associated deaths. In December 2018, again, we received a report of cases, and the total, there was around 121 cases and 14 associated deaths. In beginning of this year, around 2 cases came to Addis Ababa, and during investigation, they were suspected to be of yellow fever cases. Investigation were done, and truly they came positive for yellow fever. Now, following up these cases, they took us back to the same Southern Nation and Nationality region, whereby WHO and the Ministry of Health and partners immediately, we embarked on an investigation. First of all, we reactivated the rapid response teams, which were already trained at the regional, zonal, and Warada, which is like a district here. And then also the response organogram was again prepared, and we started the investigation. We conducted the yellow fever investigation, and we sent epidemiologists, we sent entomologists, and we sent the surveillance officers on the ground to investigate the case. At the same time, we strengthened active case search, which were conducted throughout the outbreak area. And as a WHO Health Cluster coordinators, we also mapped our partners and stakeholders in order to involve every single hand in this investigation. Now, after the investigation, both epidemiological investigation and entomological investigation, we prepared a response plan. And that response plan, based on the response plan, we conducted a reactive vaccination campaign in around the area where the cases were being reported at the epicenter. And the target we were able to vaccinate 36,000 or close to 40,000. Now, however, you see we were able to vaccinate around 40,000, but when we looked at the percentage coverage, was just 66%, and definitely we know that this percent was too low. But again, one could ask ourselves why the percentage was low. Could have been probably we were wrong in the denominator, because this is a very rural area and a vast area, so probably the denominator was wrong. And then now we just completed a really mass vaccination campaign for yellow fever, where we targeted around 700,000 individuals, and we were able to vaccinate, the vaccination coverage was around 93%. One would wonder, yes, we are saying we did this. Now, what was WHO specific intervention? WHO, we provided a technical support on case management, and that including providing job aids and providing trainings, and also providing experts to on the ground in order to support the local authorities. We also provided surveillance and active case searching in terms of logistic capacity. And then we deployed entomologists, epidemiologists, and surveillance officers on the ground to conduct the investigation and to support the regional authorities in planning the response. In addition to that, once we confirmed it was a yellow fever, and we decided to do reactive ring vaccination, and this vaccination, we supported the region in preparation of the micro plan, which were followed by rats and the like. And also we followed the training of the supervisors for the vaccination campaign. And then we also support on surveillance and vaccination data management. And we did not end up there. Even after vaccination, we provided support in following up adverse effects monitoring of the vaccine. Major gaps that we identified during this whole operation was a micro planning gap. Figures, as I had previously said, probably were overinflated because of the region being very remote and a vast area. And then at the initial of the during preparation for microplan, we were having shortages of mixing syringes, but we were able to get them timely for the vaccination. And then there was some minor bottlenecks and a delay in dispatching of the vaccination equipment and vaccine in some of the areas. So we have seen there was both underperformance as well as overperformance. Lessons learned. Lessons learned, we saw that with a good political and the administration engagement of from central all the way to the local authorities was the key issue into this successful campaign performance. We have seen that by ensuring availability of necessary logistics ahead of the campaign should be a top priority. Training of the healthcare professionals for this activity is mandatory so that to ensure the success of the campaign. And that I think is what we did, and we got this success. Thank you very much, and wishing you all the best.
Thank you very much, colleagues. That was from Agri Bategeretsa from WHO Ethiopia. So we've reached the end of our country presentations. Now it's a chance for us to hear from you, to hear what you want to hear from the presenters. We have some questions in Slido, so I'm going to go through them, not exactly in the order they were presented in, but partly in the order in which the interest is. The first question, though, is for Nigeria from an anonymous participant. And goes as follows. It was mentioned that no new cases have been confirmed after the vaccination in Nigeria. Is this also considering all samples sent to Institut Pasteur Dakar? Bassi, if you're online, that would be for you.
Okay. All right. Thank you for the question. At least we've not had that feedback from Dakar yet, but the interesting thing is since the team moved in there on the 7th of November and worked with the state, fast-tracked their micro plans, and then started the vaccination, the number of cases drastically reduced, because this was followed on the 4th day with the campaign that the people in those local governments, for instance, the Delta, about 422,000 persons, 9 years to 44 years were targeted. So immediately they started those campaigns, and then they were given the vaccine. We have not seen new cases of death or reported deaths in those areas. This is heartwarming, because unlike then, almost every 1, 2, 3 days, you hear a death being reported, but this is not happening. And we want to believe that the vaccines are working and the people are being saved. Thank you, over.
Thank you for that. Let's hope it's so. We have a general question that several presenters could respond to, and it has been liked several times. It's from our colleague in the WHO country office in Nigeria, from Terna Mhwange. The question is as follows. Most of the presentations in Africa focus on preventive mass vaccinations. What is the approach towards improving yellow fever coverage, reduction of the yellow fever MCV1 gap? Question. Who would like to take that one?
Okay, I think I can still start. I want to acknowledge that question. It's a very important one. And that's why for us as a country, since we had the guidance and the launch of the I strategy in 2018, and we looking at the protecting our risk population, we didn't just want to base the protecting the risk population on campaigns only. We thought of improving the routine immunization vaccination and ensuring that our children at 9 months are properly immunized. And as I mentioned, yes, the unique estimate of 2019 is showing us about 53. But we could see from the SMART survey that is the preliminary result that came out is undergoing validation now by World Bank. It shows that about 71%. You could see there is an improvement between that period and 2019, 2020 on the routine immunization coverage for yellow fever. And upon all the cases that have been recorded so far, for those age groups that have received routine immunization at age 9, since we commenced routine immunization vaccination for our eligible children over 10 years ago, we have not seen any deaths reported yet among those cohorts, which means the routine immunization vaccination is improving. So efforts are ongoing through the OIRI strategy to ensure that, just like every other antigen, we'll make sure that the routine immunization, there's a gap is breached, and then the gap between the yellow fever and other antigens given at the same point and also earlier in life is also breached. We could see, for instance, from the support we've had from partners that are online here and our donors, and also the international community, the gap between admin and the survey data in the country is breaching. As at 2016, we had 73% gap. As at this year, with the last survey, it's about 13% gap. So we want to believe those gaps are improving, and efforts will still be on to ensure that our routine immunization with the yellow fever, all the gaps are breached. This is the priority for the country. Over.
Thank you, Basi. Our next question is for Noeli. So next question is for Brazil. I hope you have interpretation on for colleagues who don't understand Portuguese. It's from Isabella Rezende. The question is, regarding the presentation from Brazilian partners, where can we find this data about viral dispersion prediction? A very specific question. Can anyone see if Noeli is still online with us? Yes, she is.
Sim, sim. Yeah. Obrigada pela pergunta. Pode ser verificado nos boletins epidemiológicos que o Ministério da Saúde disponibiliza no site do Ministério, pelo site Ministério da Saúde, @saude.gov.br. Eu posso disponibilizar depois para a Secretaria para que possa ser disponibilizado a todos. E no site da Fiocruz também tem um link sobre a plataforma Sigel e que explica alguns pontos sobre a questão dos corredores ecológicos e da plataforma Sigel.
Obrigada. Thank you for that as well. I see that our colleague Blaise from Afro would like to add to what Dr. Basi said as well. This was the question on Nigeria. Blaise, would you like to come in?
Yeah, thank you very much, Nika. Just to add on what my colleague from Nigeria has said related to the routine immunization. It is true that the routine immunization component is one of the gaps we are observing in the implementation of the eye strategy in African region. And this is why the Afro implementation team is working together with the vaccine delivery working group from the eye strategy to try to improve yellow fever routine immunization in African region in all the countries. And one of the steps we have done is to work together and to go with the survey on the routine immunization policies in the country. And this will allow us to identify what has the gap, what has the barrier in the implementation of routine immunization, improving routine immunization coverage. So once these barriers are identified, then there will be a plan which will be set up and which will be implemented to respond to this situation of improving routine immunization coverage in Africa. Over to you.
Thank you, Blaise. Next, we have a question for Agre, a question on your presentation, Agre. It's from an anonymous colleague. The coverage in Ethiopia was 66%. What is the way forward? Is this administrative coverage? Do we have results of independent monitors or LQAs? Over to you, please. Let me know if I should repeat the question.
No, the question is, sorry, I can't put the video because of the internet fluctuation, but that one, 66% was during a ring vaccination. And that is, as I said, probably it was because we had the wrong denominator. But if you see during now a bigger vaccination campaign where we targeted around 700,000, the percentage was around 93%. Yes, and so those are the difference exactly.
Thank you very much for that.
But
I'm going back and...
In addition to that, sorry, I just wanted to, in September this year, we were planning already to do a request to start routine vaccination. But because of COVID, yeah, everything got confused. So we never even sent an application for that. But the way forward is to, with the nearest possible opportunity, as the country is going to start requesting for yellow fever as a routine vaccination. Yeah.
Thank you for that. We have further input on improving routine vaccination. This is from Kofi Boateng from Ghana, who's on Zoom actually. Can we invite Kofi to participate?
Thank you very much and good evening. I'm Kofi, but I'm working with WHO Nigeria and we're supporting Dr. Bassi and his team. I think one of the concrete measures we have to focus on in terms of improving uptake of yellow fever vaccination through routine immunization has to do with ensuring that we also prioritize for areas that we have very high burden of unimmunized population like Nigeria, the integration of routine immunization interventions during SIAs. We are investing millions of dollars in this direction in Nigeria, and I think from lessons from the polio eradication, as well as other integrated SIAs experiences, what we need to do is to have that flexibility to prioritize resourcing additional teams that will focus on improving on yellow fever vaccination uptake, taking opportunity of all SIAs that we conduct. Secondly, based on the risk profile that we have, the country recently implemented the IMOP, a kind of a peer intervention to try to reach out to over 409 LGAs with all routine antigens, including yellow fever vaccines. I think this is a laudable experience. The first round was conducted, the second round has just completed. And we have examined that even in that process, we are reaching out to children way beyond the 9 months eligibility for yellow fever. So we're trying to use that strategy to do that. And it is important to say that it will be useful to have recommendations around using the yellow fever, the I platform, to support countries with these high burden of unimmunized children to be properly resourced to reach out to children beyond 9 months of age. And that will contribute significantly in strengthening the second year of life agenda as Nigeria is pursuing now. Then the thirdly is the issue about using the PAC lens in terms of our discussion. How do we integrate our yellow fever interventions to strengthen primary healthcare systems for the country? I think we have enough support from this platform, but in terms of alignment and actual deliverables in terms of how we push the agenda of integration. We have highlighted the issue of surveillance. We have highlighted the issue of routine immunization, laboratory support. I think we need to reflect more on that, how we can have more palpable interventions in this regard so that we can bridge some of the gaps. Thank you so much.
Thank you for that, Kofi. I just wanted to say in your answer, you addressed a question that we had earlier from Chris Gregory, which was on what are some of the lessons learned and challenges from other campaigns. And I think you spoke directly about that already. Thank you so much. Some of the other questions we won't get a chance to address today, but they will be discussed tomorrow. That's around surveillance and laboratory. Tomorrow, there will also be more discussion on the impact of COVID as well. We just have very few minutes left, but we had a few questions that came in on the risk session after we had wrapped up on the risk session, but I think we rushed a little bit, so we might have a chance to address this now. Alba Maria, this one would be for you. It's from Dr. Anthony Onimisi. He says, please kindly help us with the innovative ways of doing routine immunization in PAHO. What are they doing that Nigeria can learn from them? It might not be something you can answer specifically now, but it looks like a good topic for sharing further. But I'll just repeat the question for Alba Maria. Kindly help us with the innovative ways of doing routine immunization in PAHO. Do you want to take a few moments on that one?
Yeah, thank you so much for the question. I would like to say that the first key or critical component of the routine immunization here at PAHO is that the vaccine had been introduced into the routine programs many years ago. And that is part of the package of the all vaccines that children have access. Innovative ways, I would say that campaigns in zootic area have been very successful. And also the vaccination of travelers to exotic areas, that is important for us to maintain the immunization and trying to decrease the risk of transmission of yellow fever. But I can elaborate a little bit more and can share in written for the person who made the question. Over. Thank you.
Thank you, and that's precisely why the app, I think, is useful, the WHO events app, which you can have on an iPhone, you can have it on Android, you can find it in the App Store, you can find it in Google Play, and that's where you can continue on with some of these discussions if you can't email a colleague directly. And it's a nice way for other colleagues to see as well. There's also a web version of the app. The links have been sent to you before. You can reach back to the Secretariat if you don't have them on hand. Just going to go over a few questions, also from Anonymous. There's somebody maybe has their, maybe you need to mute. I'm getting a bit of feedback of myself. I don't want to hear myself more. Two questions. First one, a golden opportunity for Nigeria to be confirmed as a reference lab due to the COVID-19 issue. That's more of a comment than a question. The next one is a question. Nigeria COVID-19 problems with shipping samples to Dakar. Nigeria had published genetic sequencing of yellow fever isolates. Why not use country resources and facilities rather than shipping to Institut Pasteur Dakar? Any comment on that one? Over to colleagues in Nigeria.
I think for us in Nigeria, we just want to use this opportunity to appeal to WHO, all our donors and colleagues here, for the opportunity for the reference laboratory, regional reference laboratory, to also be finalized here in the country. It will really help us for timely confirmation and intervention. And of course, like mentioned earlier, with the COVID second wave that is ongoing, it would really be an opportunity for us to have our samples confirmed. You could even see in this meeting, there's a question whether the results that are coming in from Senegal are still not showing positive for some of them who have died. The delay is just because of the COVID, and we really need assistance to get our regional reference laboratory here confirmed. Thank you, and over.
Thank you for that. So we just have 3 minutes left, and I'll just do a quick wrap up, more of a look ahead actually for tomorrow. So we mentioned already that there'll be more discussion of laboratory and surveillance tomorrow, more of a chance to discuss the impact of COVID as well. So I just wanted to thank you, colleagues, for your patience, for your participation. It's not an easy format. It's hard to feel involved when we're doing it this way, but so many of you have stayed online this whole time. Thank you for those. Thank you for the interpreters. Thank you for those who have technically made this possible. Thank you for colleagues who have scrambled at the last minute to find the best way to make your presentation, recording a video at the last moment, just to make sure that others would be able to hear your country situation. As we've referred to several times, you can continue the discussion on the WHO Events app. You can also have a look at the social media package that was sent to you earlier if you want to tweet. There's all the materials you need so that you can let others know that you're participating in this meeting. I think that is it for today. We look forward to seeing you again tomorrow, same time as the meeting started today. So that's 3:30 for us here in Europe. And in the same way, we will wrap up 3 hours later. If you have further questions or concerns, use the app and see if you can get onto Slido for tomorrow. Thank you all, colleagues. Laurence, did you want to jump in again and say a few words as to end the day?
Not really anything to add, Nika, except renewing my thanks and appreciations for everybody's presence in this very busy time, and reflecting your engagement and how important this topic is. Thanks so much to all, and thank you, Nika, for the great facilitation. Over.
Thanks, everyone. Have a good rest of your day, a good rest of your morning, good rest of your afternoon, good evening, and good night. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye.
And see you tomorrow.
Bye-bye tomorrow.
Bye-bye. See you tomorrow.
Okay. Bye-bye.